Thank you very much, Dr. Rain, for that lovely introduction. And again, I apologize to everybody in the audience that I sound a little nasally, and if you could see me, you would see the Rudolph nose as well. I've been a little under the weather, but I'll do my best, and I'm just apologizing. Hopefully I don't lose my voice, but for those of you that know me, I talk a lot, and I've never lost my voice, so it should be okay. But anyways, I've been given this relatively contentious topic, is it time to limit weight gain in pregnancy? And I believe I was given this topic based on a van ride when I was at the Obesity Society meeting, when I was in a van with Arya Sharma and a few other CON members when we were on our way to a dance club. And so some people in the audience might have been there in the van at the time, and he told me, he's like, you know what you should really do? You should write a scathing editorial about. And this was the title. And I wasn't really expecting to be invited to give this talk, but here I am. So I'll do my best to talk about this. So again, I have no disclosures to make. The learning objectives, as you probably read in your pamphlet. Okay, so this is a little bit of audience participation here. And maybe it's only the women in the audience that might have to answer this question. So, I never had a weight problem until. I did my PhD. Well, maybe when you did your PhD, but it's normally until I had kids, or I was pregnant and had kids. We hear this all the time. So with the women that we deal with in our population, oftentimes we hear, I was a lean person, I was really fit, I was this, I was that, until I got pregnant and had kids. Another audience participation question. So, how many people in the room know someone who has gained more than 50 pounds during pregnancy? So, the majority of the hands have gone up. How many people know of somebody who's gained more than 80 pounds during pregnancy? Again, quite a few people with their hands up. So, I guess what I'm asking is that okay? Is that an acceptable amount of weight gain? Should we expect women to gain 50, 60, 70, 80, 90, 100 pounds? These are not uncommon weight gains during pregnancy. So the average weight gain in pregnancy has dramatically increased over the last 4 decades from about 10 to 15 kilograms. Mean pregnancy weight gain has increased in all pre-pregnancy categories, so from the very, very lean women to very obese women. So all women have increased their weight gain over time. So for those of you that were at my workshop yesterday or have been at any of the talks, you've probably seen this. So these were the 2009 Institute of Medicine guidelines for gestational weight gain. So this is highlighting overweight and obese guidelines, so the recommendations of how much an overweight or obese woman should gain during pregnancy. So the difference between the old guidelines, the 1990 guidelines, and these ones is like the bottom right-hand box where it used to say that women who are obese could gain anything over 6 kilograms. So it was basically indefinite. So they've, in the light of sort of the obesity epidemic and the concerns we have now about child health and maternal health, including postpartum weight retention, they considered the group that made these guidelines considered both fetal and maternal outcomes, and these are the numbers they came up with. So you can see that in comparison to an underweight and a normal weight woman, an overweight or obese woman, they have a much smaller range. So they have a smaller number that is considered acceptable to gain. However, shortly after these guidelines were published, they were criticized, or there's been several papers that have been published afterwards saying, really, those are too liberal. We still think that those are too liberal. We know that you looked at the evidence, but, you know, there wasn't enough obese women in the evidence that you looked at. So I'm just going to highlight a few of the ones that came after the fact. And for those of you that know Raoul Lartal, he's very adamant against these guidelines, and he thinks that they need to be more conservative. So I'm quoting here, the Institute of Medicine Committee's adherence to its previously published recommendations that focus on theoretical prevention of low birth weight due to deficient nutrition is biologically insupportable given affluent Western diets. He's on record having said this, he's published this, and he says it quite often. He is one of the opponents of these guidelines and the proponent of limiting gestational weight gain. So when it comes to gestational weight gain, as I mentioned, there's a smaller limit for overweight or obese women. And overweight or obese women are 3 times more likely to exceed those guidelines. So that's not necessarily that they're gaining absolutely a greater amount of weight. It's just they're gaining outside of those guidelines. Not saying that there are not overweight or obese women that gain absolutely a large amount of weight. But again, they can exceed their guidelines more easily because it's a smaller target. So in a population that we were looking at, the Ottawa and Kingston birth cohort that my student Zach Ferraro looked at, we found that excessive weight gain was very common in all weight gain categories. So normal weight women, overweight women, and obese women. So about 80%, like almost 80% of overweight women exceeded the guidelines, and again, 72% of obese women. So this is the majority. But again, almost 50% of normal weight women also exceeded the guidelines. So we're talking most women exceed these guidelines. Why are we worried about gestational weight gain in the first place? So, like, why aren't we just telling every woman in the world to monitor it and be really, really careful and you know, gain as least amount of weight as possible? Well, we worry about preterm birth. We worry about small for gestational age. We worry about ketosis or ketonuria. We worry about perinatal morbidity. We worry about breastfeeding initiation and duration, because there is some evidence, old evidence and evidence from certain groups that have shown that some of these things might be associated with inadequate gestational weight gain. But what about excessive gestational weight gain? So what are the things that we might be concerned about? You'll see as I go through these that there are some commonalities between what we worry about in inadequate and what we worry about in excessive. So greater incidence of preeclampsia, again a comorbidity associated with pregnancy, increased risk of gestational diabetes, adverse pregnancy outcomes, higher C-section rate, instrumental delivery, and NICU stay, etc. Breastfeeding initiation and duration, we're also worried about that in women who gain too much weight. Postpartum weight retention and postpartum maternal obesity, again, that means a woman who's gained weight during pregnancy and holds on to it after pregnancy, and then herself might become obese or overweight, or at least move up in the BMI category, and then increase weight before subsequent pregnancies. So there's women who gain weight during one pregnancy, hold on to a bit, and they go into their next pregnancy bigger than their first. And it's sort of a cyclical pattern, which we would ultimately like to change. What are we worried about in the child with excess? Risk for fetal macrosomia, so that's a really big baby. Increase in fetal adiposity. So not only being born big as in heavy, but being born with a large amount of fat tissue. Perinatal morbidity, again, you'll remember that we were also worried about that with women who are inadequate weight gain. Increased risk for downstream obesity and cardiometabolic complications. Again, this is a very popular focus right now, is that, okay, what happens in utero can really make an impact on what happens down the line. So this is a figure that our group has published recently, basically just illustrating the sort of intergenerational cycle of obesity. It's an obese mom providing the growing fetus with an abnormal metabolic environment. They give birth to a large for gestational age infant who again follows the aberrant growth trajectory by the time they reach adulthood, and if they happen to be a girl and they're ready to give birth, again this pattern continues or can continue. It's not all doom and gloom, does not necessarily have to continue, but does in some cases. So, but why is gestational weight gain important? This is a very old slide, but from Pitkin, I think 1979. So there's some biological importance. Obviously, you have to gain weight for various reasons. So you can see that on the bottom, it's over the duration of pregnancy. So pregnancy is generally about 40 weeks. Up the right side is how much weight in kilograms the mother is putting on herself versus the fetus. And on the left side is the weight gain in kilograms, so that you can see there's blood, uterus, breast, other tissue being fat, which is in there, extracellular fluid, amniotic fluid, placenta, and fetus. But if a woman is already carrying an extra 20 or more kilograms of fat, is that still necessary? Is all that weight gain still necessary? So theoretically, can a woman who's significantly overweight still gain the appropriate pieces of that but not gain fat herself, or lose her own body fat while gaining for the baby? Can that happen? And I think that there's evidence to support that can happen, and there's people that would certainly argument that can happen. So when you put on too much weight, what are we worried about? Why are we worried about too much weight? We're worried about too much weight not only for baby but for mom too, because there's some evidence to suggest that all women put on a certain amount of visceral adipose tissue, so the fat around the organs essentially. But if a woman already has a lot of subcutaneous fat and it's full and it's spilling over into the visceral depots where it might have already been, she's just increasing her risk of cardiometabolic disaster down the line. And she's also putting her child at risk as well, who might be seeing some of this extra weight. So can a woman gain less than the, oops, sorry, my apologies. can a woman gain less than the Institute of Medicine target without undue risk? So essentially that is what the topic of this is about. So yes, depending on where she starts. So my belief is yes, and I think many people would agree with me on that. This is some data from Cedar-Gren, and this is from Scandinavian population. So it's about 300,000 births from the Swiss, or not the Swiss, sorry, the Swedish medical birth registry. Essentially, if you're born in the Scandinavian countries, it seems that you're tagged for life, and they have all this information on you. They follow you forever, so they have really great data sets that you can look at these sorts of things. So I'll orient you to this, these graphs here. So along the bottom is the kilograms of gestational weight gain, and along the y-axis is sort of the odds ratio of adverse events. So these odds ratios here are of a collective maternal and fetal adverse events. So we have underweight, top left, normal weight, overweight, and obese. So this group was saying that sort of the optimal range, which is when the odds would be less than 1, so you're improving things, less than 1, that the adverse effects is about 4 to 10 kilograms in an underweight woman, about 2 to 10 kilograms in a normal weight woman, less than 8 kilograms in an overweight woman, and less than 6 kilograms in an obese woman. So again, for the overweight and obese women, this suggestion is less than the Institute of Medicine guidelines. So moving on to another study, and this one was done by Deborah Keel's group, and they were looking at about 120,000 pregnant women from Missouri. Similarly, they were looking at different classes of obesity, because this is something that's been criticized in the Institute of Medicine guidelines, that when they gave a cutoff for obesity, it was just everybody with a BMI of over 30. We all know in this room that there's a big difference between somebody with a BMI of 30 exactly and a woman with a BMI of 40, 50, 60. Obviously, these are different animals we're talking about. So to paint them all with the same brushstroke and tell them they all should be gaining the same amount of weight probably is really inappropriate. So this particular group wanted to break it down into the different classes of obesity. So class 1 obesity, so those between 30 and 34.9, it was suggested, or the sort of the optimal weight gain category that would reduce the preeclampsia, cesarean delivery while protecting from gestational age, and again improving the LGA, or large for gestational age, data. They found that it was about 6 to 9 kilograms was the appropriate zone for somebody who has a BMI in that category. When you move on to class 2, moves down a little bit, again for the same thing, trying to limit all of these adverse events, taking into consider all of them. 0 to 4 kilograms was considered the optimal range. And this might be a surprise to some of you, but for those women who have a BMI of greater than 40, in this particular study, a weight loss of -3 to -5 kilograms was actually optimal for these women, for their own maternal outcomes and the outcomes of their child. So again, this is sort of going against those Institute of Medicine guidelines, but playing into, as I mentioned before, the opponents of this saying that these are too conservative. And so what they were trying to get at is these are too conservative for certain categories. So again, this is another study looking at something very similar. This one was looking at an American data set. So I think it's the National Longitudinal Survey of Youth in 1979. So this was essentially it's a cohort where they followed people. Not only they followed moms, and then they followed their children yearly and then biannual after that. So this group was taking into consideration all sorts of outcomes as well. So small for gestational age, which I've highlighted here in red, large for gestational age in blue, C-section, which is black, child overweight, which is green, and postpartum weight retention. I can't even really see. Anyways, the big one is postpartum weight retention, the one that goes way up if you gain excessive weight. So again, the x-axis is gestational weight gain in kilograms. The y-axis is the risk. So they looked at, again, underweight, normal weight, overweight, and obese. So in the underweight category, you can see this is where the optimal zone was. So that was essentially where large for gestational age and small for gestational age were both less than 10%, which is sort of the expected population level of this. So they figured that the point of best and optimal weight gain was where those would meet. Here it is. So it was just about 25 kilograms for underweight. It's about 15 kilograms for normal weight. It's about 5 kilograms for overweight, and it's off the charts for obese. So they're saying that 0 they don't actually cross here. You couldn't really tell. They didn't have enough data to be able to support it, but it's less. Now, this is an interesting study by Emily Oken and Matt Gilman's group in Boston, where, again, they were looking at something very similar. So they were looking at multiple adverse outcomes, so postpartum weight retention, child obesity, large for gestational age, small for gestational age, and preterm birth. So all of these are graphed here in the separate colors. They looked at normal, overweight, and obese, and looked at the odds of each of those as gestational weight gain per week. So the sort of rate of weight gain goes up, what happens. So this was from Project Viva. So it's a smaller study than the other ones. These are, I think it's about 2,200 mom-baby pairs. So the average predicted probability of the 5 adverse outcomes, so they were taking sort of a composite of all of these and where the weight gain or the optimal weight gain range would be. So if you can see here, the red line is normal weight women, and what they determined from this analysis is about 0.28 kilograms per week was optimal, or 11.2 kilograms over that 40-week term. Overweight, it was again a slight loss of 0.03 kilograms per week, and in obese, it was 0.19 minus, so negative 0.19 kilograms per week. So again, they were alluding to the fact that to get the best outcomes for all of the outcomes that they were looking at, it was best in this obese group to be losing a small amount of weight. So interestingly enough, this particular study considered, at least this analysis and this piece, considered all of these outcomes to be equally undesirable. But for the clinicians in the audience, we know that they're not all equally undesirable. There's certain ones that people are much more concerned about. So this group polled a set of experts and asked, okay, so out of all of these things, which ones do you think are worse? And then we're going to redo the analysis weighting them worse. So they looked at a group of, I think it was 12 experts, and 5 of them thought that preterm birth and small for gestational age was a really strong one. Quite a few of them thought that postpartum weight retention was a big one, and others thought that childhood obesity down the line. So they took what their peers had said were the most serious, and then they redid the analysis, weighting it differently. And so all I can say is, if the child outcomes of small for gestational age and preterm birth were considered the strongest, everything shifts up a bit, at least for the normal weight and the overweight women, meaning then you get a little bit more liberal with your weight gain categories. However, in the obese women, it didn't change at all, so it didn't modify. Still, the lowest weight gain is the best, and a weight loss is considered the best in that group. So I thought that was an interesting way of looking at it by weighting these things rather than thinking that they're all considered the same. This is a very similar study. This is the Hinkle study. Again, this was using a big population cohort, the Center of Disease Control, pregnancy nutritional surveillance system. So they looked at about 122,000 women. And again, they are looking at small for gestational age and gestational weight gain, as well as large for gestational age and gestational weight gain. So these are the classes of obesity. So moving from left to right, that is class 1, class 2, and class 3. On the left-hand side, those 3 ones are small for gestational age, and on the right, those 3 ones are large for gestational age. So the ones that I've boxed there, that's what they found was the optimal zone for these women, for that you're not impacting small for gestational age, so not increasing the risk for SGA, but decreasing the risk for LGA. And they found that zone, the best zone, was from minus 4.9 kilograms to a gain of 4.9 kilograms. And that was the best pairing of those two. So they found, particularly in the big women, so the class 2 and class 3 obesity, that a weight loss of 4.1 kilograms was sort of optimal. So the lowest absolute risk of developing, they looked at other things, so preeclampsia, cesarean birth, infant size being SGA or LGA, was 0 to 4.1 kilograms. So another thing that I mentioned, one of the concerns, what about ketosis, what about ketonuria? So are we putting the fetus at risk? Are women, are they often going to be in these states? So my clinical colleagues have told me that that ketonuria develops in about 10 to 20% of normal pregnancies after an overnight fast and may actually protect the fetus from starvation, and that a small degree of ketosis occurring in pregnant women is unlikely to lead to measurable deficits in the newborn, particularly in our society when we do have access to food all of the time, and generally any periods of fasting are quite limited. And again, there are studies that have looked at women who fasted during Ramadan, which I guess would probably be, for our population, would probably be the most significant time that we might find a woman who is really limiting their caloric intake or fasting for a period of time. And all of the studies that I was able to find that have looked at that have not shown that month, the Islamic month of fasting, to be associated with an adverse effect on the fetus. So again, I happen to share kinship with Artal on some of these things. I'm not a clinician, he's a clinician, but this is what he said about this. The IOM committee also reemphasized a historic concern that restricting weight gain in pregnancy could result in ketonuria or ketonemia, causing adverse fetal neurodevelopment effects. This cause and effect concern has been discredited. The use of maternal ketonuria and potential effects originates in one single study from 1969, and he says that it's been criticized for its improper design because of data being obtained in different hospitals with a nurse obtaining a single sample, da-da-da. Anyways, going on. And the fact is, he's saying that this was associated with low neurodevelopment and low IQ in the kids, but he's going on to say, but maternal IQ, which is one of the strongest predictors of child IQ, wasn't taken into account. So he's essentially refuting that argument. So, stricter guidelines for overweight and obese women. These are sort of the concerns. Are the weight gain targets we have right now too high for overweight and obese women? Do weight gain guidelines take into the potential for postpartum weight retention? Do they take those seriously enough? So again, they're considering the child, which obviously is important. We certainly want to avoid low birth weight and small for gestational age, but at the same time we want to think about the mom and her downstream complications and what that could mean for the baby. So again, should guidelines take into consideration the severity of obesity? So should we be considering it all as one, or should we be considering the three different sort of classes of obesity? And I know many clinicians that do already, without needing guidelines, sort of treat this differently when they see their patients. They already are asking their very, very obese patients to limit that gestational weight gain if at all possible. And then again, do these guidelines apply to just women with gestational diabetes? Because there's really no talk about that specifically in the Institute of Medicine guidelines. So the latest sort of position statement from the American College of Obstetrics and Gynecologists, so Acog, on weight gain during pregnancy. So they said for the overweight pregnant woman who is gaining less than the recommended amount but has an appropriately growing fetus, no evidence exists that encouraging increased weight gain to conform with the current guidelines will improve maternal or fetal outcomes. So again, they're kind of couching themselves here. Similarly, for an obese pregnant woman who is gaining less weight than recommended but has an appropriate growing fetus, no evidence exists to encourage them to conform to those guidelines will improve their maternal or fetal health. So for both overweight and obese, basically this position statement is saying if everything is going fine, if they are, below guidelines or even losing weight, but their fetus is growing appropriately and by all the measurable assessments, it seems that everything is fine. Why would you encourage them to gain any more? So there's also some evidence from bariatric surgery, again, with regards to if it's helpful to limit that weight gain for mom and baby. So the latest review, 2011 review, said that we know that it helps mom prevent GDM, lowers the risk of hypertension and preeclampsia if she's had bariatric surgery. But what the reviews have also found that in the women post-bariatric surgery, there's a lower risk of macrosomia without increasing the risk of low birth weight babies or the risk of neural tube defects. So this is when they were comparing women who'd had a child before they'd had bariatric surgery in comparison to the same woman post-bariatric surgery. There was no effect on the duration of breastfeeding. Again, as you remember in one of my first slides, that was always a concern. And maternal surgical weight loss lowers the prevalence of obesity and cardiometabolic risk factors in the offspring until the adolescent years. So again, some of these studies retrospectively looked at women, and they could then look at their children at that time. So the children that were born pre-bariatric surgery were much larger, had much higher fat mass, and had more cardiometabolic dangers or cardiometabolic risks than those post-surgery. So is there room, take it a step further, for weight loss in pregnancy? Some of those slides have basically said yes, with caveats. So again, not across the board, only in certain populations. So I'm going to talk very briefly about these two studies that have really looked at weight loss and compared to women who are meeting the guidelines. So the Berlin study from 2010, so that was looking at a large Bavarian population, about 7,000 births, And then the Blomberg study, which was separated things into class 1, class 2, and class 3, again from the Swedish Medical Birth Registry, where they seem to have just a plethora of fantastic data. So let me orient you to the slide. So we're looking at all the sort of contraindications or problems, and then there's gestational weight loss. Then there's non-excessive gestational weight gain, so that's women who are meeting the criteria, and then there's excessive gestational weight gain. So you can see, oh, I'm being told to stop. So basically what this is saying is that there's not huge differences in birth weights or gestational age, but what this tells us, if we look here, so there's sort of a reduction in a lot of the maternal characteristics. So if you lose weight during pregnancy, and if particularly if you're in the larger classes, you're improving all of your maternal outcomes. However, there's some concern that there might be some problems with small for gestational age infants, that it might increase the risk, at least in women who are overweight. Certainly not in the class 3 obesity, they didn't find that. Similarly, the Blomberg study found very similar results, that if you gain less than 0, 0 to 4.9, or 5.9, or more than 9, 5 to 9 being sort of the optimal zone, you're really improving things for mom. You're improving some things for baby, but small for gestational age is still a concern. But small for gestational age births are uncommon in these obese women, and this group was very quick to say that their level of small for gestational age was exactly the same as what they normally see in the Swedish population anyway. So to them, they didn't find it to be really a huge contraindication, but definitely they said that the women in the class 3 obesity should look to lose weight during pregnancy. So again, this is just repeating this. Gestational weight loss may be beneficial for pregnant women who are identified as class 3 obese, and this is pretty much the same as what the Blomberg study said. Okay, so again, pregnancy is a critical time to intervene, and I will end there, although I have a few more slides, but there we go.
Thank you, Dr. Adamo. In the interest of time, we'll limit it to one question. So if someone has a burning question, please quickly make your way to the mic.
Okay. So I was at the workshop yesterday, and we were discussing a lot about gestational weight gain and how important is it to try to limit it. And this morning I was at the presentation with Jean-Pierre Després and Robert Ross. And they were saying that weight should not be the focus, but we should work on the causal behaviors. So
that was what my next slides were all about.
Okay, because pregnancy, it's a very early field. And I know a lot of women who gain too much weight, but who had a very healthy pregnancy, a normal weight baby, and they were fine. So I think because the discussing weight gain issues during pregnancy is tough, maybe we should look at those women who gain too much weight, but maybe there is a proportion of the women who were active and who were eating well. And maybe these women, it's okay, and it's not, we should maybe not discuss the issue of weight gain. So I don't know, this is really an open question, because we were discussing the fact that these women should be weighted every time they are at the doctor, and we should discuss this, but maybe we should target physical activity and diet, and if they are compliant with that, maybe weight gain is less important.
And I completely understand what you're saying, and I get it. And I suppose some of these studies, one of the weaknesses of all these large epidemiological studies is they can't control for maternal nutrition or maternal physical activity. They just don't have that data. But I agree, we have to target the behaviors. And I think that that's sort of up to the clinician then to identify if they are actually partaking the appropriate activities or behaviors. But as you know, what somebody says and what somebody does are completely different things. And weight is something measurable and tangible that you can see. You can tell somebody can tell you all the time that they do everything right, and it's not necessarily true. But I wholeheartedly agree. We have to make sure that the behaviors are in keeping. And maybe in those women, gestational weight gain is not necessarily important. Maybe the environment that they're creating with their appropriate lifestyle behavior is going to protect that fetus regardless of her gestational weight gain, and that is a possibility.
And weight loss, this is just a quick question. When you're losing weight, there is a huge lipolysis. So all the free fatty acids that you are taking outside of the cells, where are they going? Are they crossing the placenta barriers and maybe can go to the fetus? So this is another question about weight loss during pregnancy.
That's a good question, and nobody knows yet. And there was this, I was going to put up a slide, the systematic review that was looking at interventions to try to reduce gestational weight gain found no data. So there's basically no studies done yet that are trying to, although I know of a few, they weren't randomized controlled trials, so there's really no data to be able to identify if that's good or not with regards to lipolysis or various things, or how things, and again, those are very complex studies, as you know, to do, to be able to really identify what's happening and where it's going and if it's crossing the placenta. Certainly in a human model that's challenging. You can have surrogates to look at that, but that's an excellent question. Thank you very much.
Thank you.